part of Law and Ethics for Behavioral Science and Psychiatry for Falcon Physician Reviews. This is the second part of Law and Ethics for Behavioral Science and Psychiatry for Falcon Physician Reviews. So what are some reasons for involuntary psychiatric hospitalization? Danger to self, danger to others, and also not being able to take care of oneself. You can only give medication involuntary to a patient if they're imminently danger to themselves or others. Otherwise, you cannot make a patient take their daily medications if they don't want to. So it's one issue to get them into the hospital involuntarily, but once they get in there, if they refuse to take medicines, you again have to go back to court and ask the judge to sign an order to make the patient take medications. But, for example, if they become agitated, threatening to hurt you or hurt somebody else, and they need to be placed in seclusion or restraints, you can give them a dose of medication intramuscularly because you're worried that they're going to hurt themselves or someone else. Children can be committed to an institution if they pose a danger to self or others, and they can't take care of themselves, or if the parents refuse hospitalization. If the parents don't feel that their child needs to come into the hospital, if they feel like they can take care of them at home, but the doctor is very concerned about the child's safety, then a doctor can commit them to institutional care. So here are some ways that doctors can get themselves in trouble and have law cases against them. One, through negligence, abandonment, confidential violations, and boundary violations. So patient abandonment. On your exam, abandonment is if you don't return phone calls, if you don't get follow-up appointments. Say the patient is leaving your practice, you have to make sure that you find another doctor for the patient to go to. You have to document missed appointments. And you cannot deny seeing a patient if they cannot pay the bill. And this is a common cause of malpractice losses is patient abandonment. So when will a malpractice suit be put on a physician? So you have your 4 Ds, which is duty, dereliction of duty, damage, and directly. And if these are met, this is when a doctor can be sued. So if duty, if there is a doctor-patient relationship which exists, where you have reasonable standard of care, is the first point. 2, dereliction of duty. If there's any kind of negligent treatment, there can be a court case. Damage, if due to what you have done, the patient suffers in some kind of manner. And directly is that the injury is directly related to your negligence. It's not a criminal offense. Radiologists, surgeons, and anesthesiologists are the ones that are most commonly sued, whereas family practice physicians and psychiatrists are least likely. And the reason for this is because surgeons, radiologists, anesthesiologists have the least contact with their patients. Surgeons are often very busy, they don't have very much time to spend with their patients, they don't form very much of a rapport with them, and hence that's why they get sued more often. Whereas say you have a family practice physician or a psychiatrist who spends a lot of time with patients, you explain things, you listen to the patients, you're less likely to be sued than someone who does not. Many physicians say that treatment of patients as a person has a lot to do with the decision to file a case or not. So if you treat them and you listen to their needs and they really feel like you did the best you could, most likely they won't put a case against you. But if they just feel like you're just another person in a line, you're just a number, then there's an increased risk of being sued. So because of damage, what can patients obtain because of the damage that's been done? One is compensatory damage. You must reimburse the patient for lost wages, out-of-pocket or actualized losses. And also, patients can seek punitive damages, meaning they can punish the physician from gross negligence. Next, we're going to talk a little bit about Good Samaritan laws, and these are designed to protect those trying to help in emergencies. So, for example, if you're driving and someone on the side of the road is having a heart attack and you stop and you want to help, as long as you're doing standard of care procedures for this patient, you should not have any case filed against you. But one, you don't have to stop if you don't feel like you need to, and if you don't venture outside of your physician competence and you do everything that you think you should do, then there will be nothing held up against you. Also, you should not be paid for your services. What are the common reasons why malpractice is growing in physicians? Because drugs and medications, alcohol abuse have increased, physical illness has increased, mental illness and stress has increased, and also physicians are practicing longer, and advanced age impair them both physically and mentally. So what should we do? We should really try to protect our patients. If you do have a problem with a mental illness or drugs, get help. There are many doctors who have bipolar disorder, depression, who are still practicing with help. And also, you report it depending upon state laws. Let a supervisor know if you're concerned. On your exam, they will give you a vignette of a coworker who comes into the operating room who has been drinking. So the first thing you want to do is talk to the coworker. Okay, you want to talk to the coworker and say, hey, I think you should leave. You know, I can smell alcohol in your breath. I'm concerned about the patient. If he does not, then the next thing you do is go to a supervisor. So the first thing you do not want to do is to go to a supervisor. The first thing you want to do is approach your coworker first. Physicians with HIV are not required to inform patients or coworkers. Patients with HIV, though, the physician cannot say they will not treat a patient with HIV, but they are not legally obligated to treat this patient. But on your exam, you will not refuse to treat a patient with HIV illness. You must treat them. Say a physician gets a finger prick from a patient with HIV and he refuses to give blood to check for HIV, then you can force him to give blood because it is to protect the physician. And the physician is not required to maintain confidentiality of the HIV if the patient continuously spreads the risk of HIV to unsuspecting others. So if he continues to have sexual intercourse with multiple partners and he's not willing to tell anyone, then you should report this. Pregnant patients with possible HIV infections can refuse HIV testing and do not have to take antiretroviral treatment during pregnancy, even if this can prevent transmission to the fetus. Genetic testing. Most states require genetic testing of infants for diseases that can be treated, such as thyroid disorders and phenylketonuria. If it's not required by your state, it should ethically still be offered. And if no therapy is available, parents should have option of testing the child with informed consent. There are reportable illnesses that must be reported, and it depends on the state. There are certain illnesses such as hepatitis, measles, mumps, rubella, salmonella, shigella, TB, and varicella that most states require you to report. Your sexually transmitted diseases are reportable, such as syphilis, gonorrhea, chlamydia, and AIDS. And a U Assembly question for you is that gonorrhea is the most frequently reported disease. And HIV and genital herpes are not reportable, and it doesn't make any sense, but sure makes a good test question. So now we'll go on to talking a little bit about legal cases that might come up on your exam. We touched on this briefly. We're going to talk about a Tarasoff case. And what this is a case of a student who was in California who fell in love with a girl and he thought that they were dating. Well, this student was not from the United States, and he didn't know the cultural norms of dating in the United States. And he was very upset when he found out that his girlfriend was actually dating someone else. So he told his counselor that he had thoughts of wanting to hurt this other person. So what the counselor did was that they tried to detain this patient, but they did not inform this other person that he was going to hurt him. And the patient eventually ends up going and kills this person. And hence the doctor was sued for this. So what Tarasov says is that you have the duty to warn and the duty to protect. So at this point, it's okay to breach confidentiality and call the person and say, hey, so-and-so has threatened that he will hurt you. You need to protect yourself. And duty to protect means that you have every right to hospitalize or detain this patient so they cannot go out and hurt this person. Again, every state does not practice Tarasov. You have to look at your state for guidance. The McNaughton rule is that the person did not know what he was doing was wrong. So he is not guilty by reason of insanity. He did not know that the nature and the quality of the act he was doing was going to be something that he was doing wrong. And the Durham rule says that no man should be held accountable for a criminal act if it is due to the product of a mental disease. The McNaughton rule is going to be more high yield than the Durham rule will. And the pre-Hinckley law, or the American Law Institute test, says that because of the mental disorder, the patient was not able to appreciate not only the wrongfulness of his conduct, but he was also not able to conform his conduct to the requirements of the law. And the post-Hinckley test, which is very similar to the McNaughton rule, is that they were unable to appreciate the nature and quality of the wrongfulness of the act. So the difference between the post-Hinckley and the pre-Hinckley is that the pre-Hinckley is basically saying that they can't conform, and in the post-Hinckley was that they weren't even able to appreciate the wrongfulness of their act. The next case is the infant Doe case. And this is a case about a baby with Down syndrome who had a tracheoesophageal fistula. And in this case, the parents did not want the tracheoesophageal fistula fixed, and they wanted nature to let it take its course. But in that surrounding area, there were multiple people that wanted to adopt this baby, take this baby, because medical treatment could have been provided, and the child could have survived if he had been treated for this illness. Well, the court decided that it was the patient's decision and to allow nature to take its course. Now they have changed the statute to show that if there is an illness that can be treated, then it must be done for the child, even if the parents don't want it to be done. So here are a kind of a summary of how to approach USMLE questions, of everything that we've discussed so far in law and ethics. So always tell the patients the complete truth about their illness and prognosis. Just give them the facts, don't give them any opinions. You can withhold information temporarily if you feel like the information will harm the patient, but you must eventually tell them later on. Always be very honest with the patient about your role in training. If you're a resident or if you're the attending medical student, always let them know who you are. Do not allow the patient to believe that you are a physician when you really are a resident or a student. Make sure you provide enough pain relief to terminally ill patients. But don't give a purposeful overdose of an analgesic medication to shorten a patient's life. Encourage patients to make their own decisions about abortion, and encourage them to speak to family members, counselors, but do not make it so that the physician makes the decision. Never advise an abortion except when a pregnancy poses a direct medical threat to the patient. And do not advise abortion because the patient is a teenager, because the fetus has a physical birth defect, or because the parents want them to have an abortion. Patients should make their own health care choices. Relatives cannot give consent for treatment unless written directives are in place. And on the USMLE, you will never refer, transfer a patient because you can't deal with them. You'll always try to take care of all the patients on your own. And also you want to prevent an EMTALA violation, which means that a hospital is refusing to treat a patient because of any kind of religious, financial, insurance reason. If a patient comes into your emergency room and if they are not medical stable, despite if they can't pay for it, you must make sure they're medically stable and transfer them to the correct facility once you have stabilized them. Communicate with competent patients directly. Do not discuss patient's illness or care with the family members without the consent of the patient. And do not discuss patient's illness or care with anyone except if you have written consent. Discuss all options to the patient. Review pros and cons. And do not allow insurance to dictate what you should make available to your patient. On the exam, they'll give you a question. The patient comes in, he still has some suicidal thoughts, but insurance won't pay for it. What will you do? One, you will send the patient home, tell them that insurance won't pay for it, and in the very end you'll say you'll keep the patient in the hospital even if insurance will not pay for the hospital stay because you're concerned about the safety of the patient. So do not allow insurance to dictate what medications you have to give or how long you're going to keep them in the hospital. For a medication, if you feel that a patient must be on this medication, you can fill out a non-formulary request. That's a frequent question that they'll ask you on the exam as well. Never limit services based upon expenses, unpaid fees, or other assets. This concludes our section on law cases for behavioral science and psychiatry for Falcon Physician Reviews. This concludes our section on law cases for behavioral science and psychiatry for Falcon Physician Reviews.